Good evening. This is Jesse Gomez. I'm very pleased to be with you tonight. We're looking at Lowell's Community Hospital case study from Merrill. I'm with Merrill Hurst Capstone project, and it's June the 13th, 2017. So a little bit about Lowell's. Lowell's General Hospital overview is Lowell's is a 217-bed hospital which serves approximately 105,000 people. They own and operate surgery centers as well as MRI. They have 2 satellite facilities. In May of 2010, Lowell's built an additional 190,000 square feet expansion to their hospital. They have new space for a surgery center, mother-baby, emergency room, trauma, and medical surgical private rooms. And the stated reason that they wanted to do their expansion was to improve the hospital's reputation in the community. What's Lowell's community? Well, first of all, Lowell's community has a lower than average per capita income of $22,800 compared to the state average of $33,500. Also compared to the state, they have 98% of their people have insurance, 7% suffering from diabetes, 8% from heart disease. They have lower in all of their adult measures. They're lower in terms of their overall health status, and they're higher than average in the community for their smoking rates. So overall, we're seeing a lower socioeconomic group that has higher disease prevalence. So healthcare itself has problems. We in healthcare think that we are doing really well, and really we are the cream of the crop. That was a statement made by Donald Berwick, and I agree with him. I think that we basically need to continue to focus on how it is that we're going to stop lagging behind many industrialized countries and outcomes, and yet continue to lead in cost. There's a divergence of opinions on how to solve the cost problem. And what I would say is Lowell's Community Hospital really faces similar problems on the macro level. Healthcare costs are rising at a rate expected to be until 2022 at the rate of 5.8%. According to National Health Expenditure projections. Lowell's, to give you a little bit of kind of background, is again with a Blue Cross Blue Shield accountable quality contract. That contract that they have, from a root cause perspective, is really causing them problems in sort of 4 areas. Leakage, that 40% of their members are seeking care outside of their community hospital. That medical costs are declining 3 years in a row, which typically would be not a problem, except when we're looking at the fact that they're used to having a fee-for-service structure as opposed to a fee-for-value structure. They are seeing quality improving. The question always is it improving at the fast enough rate to deal with some of their community perception issues. And the 4th one is that they are a fee-for-service organization in terms of how they're structured. So 3 solution sets that have been that I've developed for the Lowell's hospital system are: number 1 is that they can continue to just can choose to leave the Blue Cross Blue Shield of Illinois contract, the AQC contract. Number 2 is that they can choose to stay with the Blue Cross Blue Shield contract, the AQC, and they can redesign their current delivery structure in order to make the necessary improvements to make that contract financially viable. Or number 3 is they could modify the relationship with Blue Cross and pursue other partnerships. So what are the pros and the cons of each one of these options? The pros in option 1 is that there's no short-term pressure on the organization. It helps them reduce their overhead costs. They don't have to bear the burden of running a AQC. It also increases the specialist referrals. Specialists will think that's a good thing. Option 2, the pros are, it improves quality. It improves cost. They are moving, by the way the contract is constructed, from a volume-based contract to a value-based contract. Option 2 suggests that they redesign their existing organizational structure. They can reduce leakage, therefore improving their profitability and their margin, and they can improve their market position. Option 3 does have some of the same positives as option 2. It does improve quality, it can lower cost, and it does allow them to continue to move in the value from volume perspective into the new way. Option 1, in terms of the cons, it's not really moving from volume to value. There is higher cost, and it is the same structure as they had in the past. Option 2, some of the cons does require leadership to think differently about the way work is done and the way that they organize those. It does put pressure on the team in the short term to do the work, and they are going to require a redesign. Those are all cons that the management team could be expressed from their clinicians to their staff. It requires option 3 requires leadership commitment. There's more risk associated with more partners, and there's more risk associated with more risk contracts. So really, what's Lowell's strategic opportunity in this business case? Well, it gives them an opportunity to define, develop, and sustain the organization's value. It allows them to produce a differentiation. How is it they can compete as a small hospital? Allows them to show why it is that they can do that. It can focus them on aligning their resources. It can develop an understanding and commitment to the community and what their needs are and being able to meet those needs. And it can drive effective accountability through the line so that everybody in the organization understands that we're moving to this value-based company and that they're accountable personally for the work that they do to help us move in that direction. As I did a SWOT analysis and looked at some of the strengths, weaknesses, opportunities, and threats, some of the strengths that were identified is that Lowell's has been able to maintain a positive margin even though they've seen declines in their medical expense. They are improving their quality year over year. They have good primary care to specialist ratio, and they are a low-cost provider in the community. Some of the weaknesses are they are seeing declines in their margin. They are a small hospital, and their illness burden is high. As you can see, 40% leakage rates are also an issue for them. Opportunities, therefore, are that their reduction in their cost is an opportunity for them. They've capitalized on the rising quality scores. They can maximize the space that they've just invested in there, the additional surgery space, ED, and they have shared savings for no patient volume. So the fact that they get money and receive money from the insurance companies for reducing volume means that there's no work that they're doing specifically for that. Some of the threats is they are seeing infighting with their PCPs and specialties, resulting in losses in both areas. If that continues, they do have a lot larger competitors that are dominant in the market. They have market consolidation that's occurring, and Blue Cross cutting the contracts with other hospitals. So what's happening sort of from a payment reform perspective? According to Gershner, you're basically seeing 3 sort of things that are happening and converging into payment reform. You're seeing commercial members moving into value-based contracts. Medicare obviously is moving into value-based contracts, which is what Lowell's is currently dealing with, and Medicaid is moving in that direction as well. So payment reform is not just isolated to Medicare. As you can see, it's really going to be an issue that will have to be dealt with across the whole spectrum of payers. So why are we going to change? I talked about contracting changing and the focus. Also, the markets are changing. I think the other reason is that leadership, according to the business case, and Lowell's wants to move forward. And so this is a chance to capitalize on their support, the need to move from volume to value, the need to support network providers through change. It's going to only position them better to be successful in their businesses as all the payers change the way that they think about paying both providers and hospitals. And of course, the Blue Cross Blue Shield of Illinois does want to reduce costs, and they do want to improve quality. So what do we see as potential barriers to make this transformation occur with Lowell's Community Hospital? The process is complicated. There's an ACO implementation guide that the recommendation that guide them goes through the implementation process that was developed, I think, from the Innovation Center and CMS, which is very, innovative at the time in 2011. They came up with an implementation plan for ACOs, and the alternative quality contract has the same premise as the ACO. So using that as a tool set to help them move forward. We're going to need to make sure that we're continuously looking at ensuring alignment with the organization's strategic goals. So the strategies are in alignment with what we're trying to achieve from an AQC and a value-based contracting perspective. We need to address cross-functional and cultural barriers. Do employees feel supported to do the right thing? Are managers rewarded for the right behaviors? We're going to see tension potentially between, as we have seen thus far, between primary care and specialists. We know, according to the business case, that that's important. And according to West, in order to be successful in running organizations, you must figure out how to support your physicians. And they do have a lower reputation in the community. So some solution criteria that we used as far as moving forward with the final determination in the case was we needed to look at bending the cost curve. We need to improve staff utilization. And this is an example of managing supply costs, but really it's bending the cost curve in total. And supplies is one of those opportunities, but there are maybe many, many other opportunities that the groups will come up with to help bend the cost curve. So what solution? Out of the three options, we saw the pros and the cons. The why was that the organization really needs to move to stay the course with AQC and redesign its service system to make the necessary improvements to make the contract financially viable. That is the solution that I'm recommending. For high-level outcome goals, that what we're looking at is sustaining and then moderating their margins, reducing their total leakage so that increases their ability to fill their existing infrastructure without needing to add days in hospitals, for instance, as an example. It means that you're just taking existing members in the community who are going outside and then enhancing and providing services that they want at your local hospital. We're going to see improvement in their quality scores. They made good progress, and we want to see that both in the inpatient setting and the outpatient setting, so marketing can communicate that outwards to the community. We're going to organize the work to do this redesign effort into work teams. As you can see by the graphic, we have a senior sponsor work team that basically starts meeting immediately, and there in week one, they're going to host a overall meeting with all the other teams, the finance team, the clinical design team, the quality improvement team, marketing, support team, and they're going to lay out the expectations moving forward. They're going to talk about the why, the how, the who is going to move this process forward. And we'll do this in a big conference center initially in week one. In week four, we'll have another get together to check the status of all the projects. In the interim space, each project will have a reporting structure where they'll either report written weekly, or they'll go back to the sponsor team if they have issues between week 1 and 4. And then between week 4 and 8, they'll continue to do their work. They'll give some short-term solution sets to senior leaders on their weekly report outs. And then 4 to 8, that work will continue. We'll see in week 8 another big gathering where folks in each of these respective teams will report out their solution sets in terms of helping to move the organization forward. Each one of these teams has an operational leader who's accountable to the senior team, and they all have a support structure underneath them. They will be using the ACO model that I propose. There's an additional model that they're going to be able to use that's going to be adapted from an accountable care organization in Tacoma, Washington, that's seen some improvement, and that hybrid model will help drive the process forward. Criteria that we want to make sure that are covered for the team is that we are setting realistic expectations. that we're setting communication expectations to the team from the senior leadership team, cross-functionally that they're communicating, that we're assuring that there's alignment with organizational goals and holding the teams accountable for that, holding the teams accountable for their outcome, and they're providing resources to do that. So as we define high level what the organization is trying to do, each team will have sub measures that they'll need to think about to that basically is in alignment with our strategic initiatives and outcomes. We will use quality improvement tools, which the support team will be well versed in, from lean to plan, do, steady, act, based on the problem that they're trying to achieve. And they're going to address any cross-functional and cultural barriers that exist either between the organization and the community, or between teams, or between hospital and ambulatory care. We need to be aware of those and make sure that we put the right structures and processes in place to address those in both the short and the long run. The team and the key considerations that they'll need to be thinking about is that we're looking for an improvement in their operating performance. We need them to understand the key cost drivers. Our medical staff is critical to us, and that means we have to have stable medical staff for us to stay in business. We need to engage our consumers, and we need to use data. All of our decisions need to be data-driven decisions where we're able to show the rationale and use the data to construct the recommendations and the process improvement. If you think about the future state of Lowell's, in the middle we have the operational redesign. We're going to see a change in the post-acute leadership, moving from a fee-for-service to a fee-for-value organizational structure. We're going to see creating true systematic integration across silos. We're going to capitalize on the efficiencies that have been created by the re-engineering of the delivery system. And we're going to support our communities to make sure that they have good health literacy, because as we know at the beginning of the case, we saw that there are health disparities in this community and their overall health status is lower than the state average, and we cannot tolerate that. And we need Lowell's to support that community. So what does this really mean overall from an opportunity perspective? It means that leadership can move from a transactional fee-for-service to a transformational, setting the pace in the community. They can move from an individual problem-solving perspective to a multidisciplinary team. As we've seen, all the implementation, there's teams of people who will create the solution sets to get buy-in from the staff. We need to move from silo thinking of hospital ambulatory care to cross-functionally system thinking, and leaders-centered to motivational value, diversity in the decision-making process and how we see the community, and seek solutions that are going to help Lowell's continue to improve their performance, as we've seen in the previous slides. So in conclusion, the system cannot avoid changing. Lowell's must change the way that they do things. Costs must be controlled. There's opportunities in the case, according to the executive directors, to see cost reductions in the 10 to 15% range. In terms of the goal set, I picked the 10% range, which is the midpoint. Leadership must transform the system. They need to make sure that they're supporting the multidisciplinary teams to achieve the outcomes they expect to meet the Blue Cross and other future payer contracts needs. Operational disruption will occur, and we need to prepare the organization's culture for that. Lowell's must focus on the re-engineering initiative over the 10-week period, and then post that 10-year period, we need them to continue to measure results, as I showed over the 3-year period, to make sure that they're not losing progress on their high-level goals, and in fact that they're improving their position across the board. And lastly, it is about payment reform, is moving us from a volume to value-based organization. Thank you for your time tonight. I just want to let you know that these are the references that I've used to present this case. Thank you.